Welcome to the deep dive. Today, we're going to explore something really quite interesting, hyperbaric oxygen treatment, or HBOT as is often called.
That's right. It involves breathing pure, 100% oxygen inside a special pressurized chamber.
It sounds a bit sci-fi, but it's a genuine medical therapy. And we're going to unpack it for you using a key source, the findings from the 10th European Consensus Conference on Hyperbaric Medicine.
Yeah, this was a major gathering. We're talking a large group of experts, European and international, who met back in 2016. Their results came out in 2017.
So not just a casual chat, they had a real purpose, didn't they?
Oh, absolutely. The core goal was very clear. Review all the existing research, really dig into it, and update the officially accepted uses for HBOT.
And they wanted it based purely on evidence.
Exactly. Evidence-based medicine was key. They used specific systems for this, like the modified grade system, to assess how strong the evidence actually was for different uses.
Great, okay. And you mentioned another system.
Yeah. Yes, the DELPHI system. That was used more to gauge the level of agreement, the consensus among all those experts. Pretty rigorous stuff.
It sounds like it. So once they evaluated the evidence and reached a consensus, how did they classify their findings? What did the recommendations look like?
They developed a straightforward three-tier system. Type 1 meant HBOT is strongly indicated. Basically, good evidence, strong agreement.
Okay, type 1 is a strong yes.
Right. Then type 2 was suggested. The evidence was decent, acceptable, but maybe not quite as rock solid as type 1.
A bit more nuanced.
Yeah.
And type 3.
Type 3 indicated a possible or optional use, so the evidence might be weaker or there's less consensus, but it could still be considered in some situations.
And they looked at the quality of the research itself, too.
Yes, that was crucial. They used levels A, B, and C. Level A is the highest, typically meaning strong data from multiple well-designed trials, like randomized controlled trials.
Level B.
Level B is still good evidence, maybe from smaller trials or strong observational studies. Level C is often based on expert opinion, case series, or less rigorous studies.
Got it. Now, you mentioned something earlier I found really interesting. They didn't just say when to use it, but also when not to.
That's a really important development from this conference, yeah. For the very first time, they issued specific negative recommendations.
Meaning they actively recommended against using HBOT for certain conditions.
Precisely. Based on solid evidence showing it likely wasn't helpful, or potentially even carried unnecessary risks for those conditions. It's a big step towards really refining its use.
Knowing what not to do is just as vital, isn't it?
It really is. It protects patients, guides doctors, and helps focus resources where they'll do the most good.
So for you joining us today, that's our goal, to give you a clear overview based on this expert consensus. We'll hit the highlights where HBOT is strongly recommended, where it's maybe suggested or optional, and critically, where the evidence says no.
Sounds good. Where should we start?
Let's begin with something unfortunately familiar, carbon monoxide poisoning. CO poisoning. What did the experts say?
Okay, yeah. On CO poisoning, the consensus was very clear, very strong. A type 1 recommendation for using HBOT.
Supported by good evidence.
Level B evidence, so yes, quite solid. And they also stressed the absolute importance of immediate first aid. Giving 100% oxygen right away, even before thinking about a hyperbaric chamber. That's also a type 1 recommendation, though level C evidence, just emphasizing how fundamental that initial step is.
Makes sense. Get oxygen in fast. So who specifically should get the HBOT according to the guidelines?
They recommended HBOT for pretty much anyone poisoned by CO who shows signs like altered consciousness or any neurological, heart, lung, or even psychological symptom.
Regardless of the CO levels in their blood.
Exactly. That's a key point.
Oh.
The recommendation, type 1, level B, holds even if the carboxyhemoglobin level measured at the hospital isn't dramatically high. They focus on how the patient looks and feels, the clinical signs, not just the number.
That seems like a much more patient-centered approach. What about vulnerable groups, like pregnant women?
Another strong recommendation there. Type 1, level B again. HBOT is recommended for pregnant women exposed to CO, period, regardless of their own symptoms or CO levels.
Because of the risk to the baby.
Precisely. The potential harm to the fetus means you treat aggressively with HBOT in those cases.
Okay. And what if the poisoning seems minor? Just mild symptoms?
For those minor cases, the panel felt it was reasonable, that's a type 3 level B recommendation, to consider either giving normobaric oxygen for about 12 hours.
So standard oxygen at normal pressure?
Right. Either that or HBOT. It's an option, but the evidence isn't as compelling as for the more severe cases.
Now let's talk about that negative recommendation you mentioned. When did they say HBOT is definitely not the way to go for CO poisoning?
They were quite firm on this. They strongly recommended against HBOT type 1 against level C evidence for patients who have no symptoms and are seen more than 24 hours after the exposure ended.
Ah, so there's a time window.
Yes. The thinking is, if you're asymptomatic that long after exposure, the potential benefits of HBOT are probably negligible and don't outweigh risks or costs. It really highlights that for CO poisoning, timely treatment is crucial.
Okay, that's very clear on carbon monoxide. Let's shift gears completely now. What about severe physical trauma? Specifically, things like open fractures combined with crush injuries. That sounds awful.
It is incredibly serious, yes. And here again, the panel gave a strong endorsement for HBOT. Type 1 recommendation, level B evidence.
For any open fracture with crush.
They particularly emphasize using it early after severe open fractures. They mentioned the Gustilo classifications, specifically types 3B and 3C.
Can you briefly explain what those mean?
Sure. Gustilo 3B and 3C basically represent really bad open fractures. There's extensive damage to the soft tissues around the bone, often contamination, maybe even arterial injury needing repair. These have a very high risk of tissue dying or getting badly infected.
So HBOT helps prevent those complications.
That's the idea. Early HBOT can significantly reduce tissue necrosis and infection rates in these severe injuries. They also noted that even for less severe open fractures, HBOT should be considered if other risk factors are present.
Makes sense. What if someone has a crush injury, maybe a limb got trapped, but there's no actual fracture? Still potential for tissue damage, right?
Definitely. If there's a crush injury with an open wound but no fracture, and doctors are worried about whether the tissue will survive, or if the infection risk is high, the panel suggested HBOT. That was a type 2 level C recommendation.
Suggesting it might be beneficial. And closed crush injuries, where the skin isn't broken, but there's internal damage, maybe risk of compartment syndrome.
For those closed crush injuries where tissue viability looks threatened, or there's a concern about compartment syndrome, typically before surgeons have done a fasciotomy to relieve pressure, HBOT was considered reasonable, type 3 level C.
But with a caveat.
Yes, very much so.
Yeah.
They stress the need for really close clinical monitoring in those cases. You want to be sure it's actually helping.
All right, you need to see results.
Yeah.
Did they mention any specific tools for monitoring?
They did. A strong recommendation, type 1, level B, that centers treating crush injuries really ought to have transcutaneous oximetry available. TP.
TCOM. What does that do?
It's a non-invasive way to measure oxygen levels right at the skin surface. Doing TCOM measurements while the patient is under pressure in the hyperbaric chamber can give valuable clues about how well oxygen is getting to the injured tissues and can actually help predict how well the patient might recover.
That sounds like a really useful objective measure.
Yeah.
Okay, moving from acute trauma to a different kind of challenge, complications from radiation therapy. Cancer treatment saves lives, but it can have tough side effects. Does HBOT help there?
Yes, this is definitely one of the well-established areas for HBOT. The consensus was strong on several points.
Such as?
For osteoradionecrosis of the mandible, that's basically bone death in the jaw after radiation, and also for preventing it if someone needs teeth pulled from an irradiated jaw, HBOT got a strong type 1 level B recommendation.
Okay, jaw problems after radiation. Anywhere else?
Yes. Also, strong recommendations for hemorrhagic radiation cystitis that's bleeding in the bladder caused by radiation, type 1 level B. And even stronger for radiation proctitis, which affects the rectum.
Stronger. How so?
For radiation proctitis, they gave it a type 1 level A recommendation. That's the highest level of evidence, usually from multiple good trials showing consistent benefit. It really highlights how effective HBOT can be for that particular, often very difficult side effect.
Wow, level A. That's significant. What about radiation damage in other parts of the body, like other bones or soft tissues?
For osteoradionecrosis in bones other than the jaw, and also for helping prevent the loss of dental implants placed in irradiated bone, the panel suggested HBOT, type 2, level C.
Suggested, okay. And soft tissue damage.
Similar suggestion, type 2, level C for soft tissue radionecrosis, especially problems in the head and neck area, but excluding the bladder and rectum, which had stronger recommendations.
Were there any radiation-related issues where it was considered more sort of optional?
Yes, they considered it reasonable, type 3 level C, to think about HBOT for treating or maybe preventing radiation-induced damage to the larynx or the central nervous system. But the evidence there is just less robust compared to the jaw, bladder, or rectum.
Okay, let's switch gears again. Thinking about divers or people working under pressure, what about decompression illness, the bends, or gas embolism?
Right. For both DCI, decompression illness, and arterial gas embolism, HBOT is the cornerstone of treatment. A strong type 1 recommendation, level C evidence for both.
And immediate first aid is crucial there too, I imagine.
Absolutely. Just like with CO poisoning, 100% oxygen via mask is vital first aid for DCI, along with intravenous fluids, both type 1, level C recommendations. Get oxygen in, keep them hydrated.
And the actual recompression treatment in the chamber, are there specific protocols?
Yes, the consensus recommended specific treatment schedules, or tables. The U.S. Navy Treatment Table 6 is a common one for serious DCI, or sometimes Heliox tables, like the Seablithe 30. For milder DCI cases, U.S. Navy Table 5 might be enough.
What if symptoms linger after the initial treatment?
HBOT is also recommended, type 1, level C, for those residual symptoms that don't fully clear up after the first recompression.
And gas embolism, where a bubble gets into the bloodstream, that sounds incredibly dangerous.
It is extremely serious. The panel strongly recommended HBOT, type 1 level B, for arterial gas embolism, especially if it causes neurological or cardiac problems.
Even if treatment is delayed.
They noted that while starting treatment ASAP gives the best results, benefits can still be seen even with some delay. And again, immediate 100% oxygen is critical, type 1 level B, while arranging for HBOT.
So get oxygen on board immediately. Anything they advised against for gas embolism treatment?
They recommended against routinely using very high-pressure treatment tables, those over 405 kPa, just because there wasn't strong evidence they were better. Though they did add a nuance, suggesting that using special gas mixes like Heliox or nitrox at higher pressures might be considered based on a center's specific experience, but that's less of a general rule.
Okay, let's talk infections now. Nasty ones, like anaerobic or mixed bacterial infections. Right. Does HBOT have a role?
Yes. Another strong recommendation here, type 1, level C for HBOT as an adjunct therapy in these infections, especially things like necrotizing soft tissue infections.
Like Fournier's gangrene.
Exactly. That's a classic example, a devastating infection of the perineal area. But the key word is adjunct.
Meaning it's part of a bigger picture.
Absolutely. HBOT must be combined with prompt, aggressive surgery to remove all the dead and infected tissue, plus the right antibiotics targeting the specific bugs. It doesn't replace those things, it works alongside them.
A team effort. What about infections deeper inside, like brain abscesses?
HBOT was recommended, type 1 level C, for intracranial abscesses, but only under quite specific, serious circumstances.
Such as?
Things like multiple abscesses, or one in a really deep or critical brain location, or if the patient is immunocompromised, or if surgery isn't possible, or if the infection just isn't responding to antibiotics alone. It's for the tough cases.
And other infections, like in the lungs or abdomen.
For those, they suggested HBOT, type 2 level C, more as a potential second-line option if the standard treatments aren't working well enough.
Let's turn to something completely different. Hearing loss. Specifically, sudden deafness, the kind that comes on quickly with no obvious cause, idiopathic sudden sensorineural hearing loss, or ISSNHL?
Right, ISSNHL. This is an interesting one because timing seems absolutely critical according to the consensus.
How so?
They strongly recommended HBOT, type 1, level B, but only if it started within 2 weeks of the hearing loss beginning. And it should be combined with standard medical therapy, usually corticosteroids.
Within 2 weeks. What about later?
They issued a strong recommendation against using HBOT, type 1, level C, if it's been more than 6 months since the onset. Doesn't matter if it's alone or with other treatments. After 6 months, the evidence says it doesn't help.
Wow, so a definite window of opportunity. What about that middle ground, say between 2 weeks and 6 months?
In that time frame, between 2 weeks and 1 month specifically, they considered HBOT reasonable, type 3, level C, as an add-on to steroids, particularly if the hearing loss is severe. But the evidence is weaker than for that initial 2-week window.
Timing really is everything there. Okay, let's tackle a very common problem. Wounds that just won't heal. Delayed wound healing. Is HBOT useful?
It can be, but again, with specific indications. The panel suggested HBOT for diabetic foot lesions, type 2, level B, and also suggested it for ischemic ulcers, those caused by poor blood flow, type 2, level C.
Suggested, so not a slam dunk, but worth considering. Any others?
They also thought it was reasonable type 3 level C for some other carefully selected non-healing wounds caused by systemic issues, like chronic calciphylaxis, which is a nasty vascular condition.
You mentioned ischemic ulcers. Did they have specific ways to decide who might benefit most, perhaps using those oxygen measurements you talked about earlier?
Yes, the TCM measurements under pressure are really key here. They gave a very strong recommendation. Type 1, level A for HBOT, if a diabetic patient's tissue oxygen level under hyperbaric conditions gets above 100 millimeters of mercury.
Level A again, wow. And for non-diabetics with artery disease?
For patients with arteriosclerosis, if their TCM under pressure was above 50 millimol Hg, the recommendation was type 2, level B. These measurements really help predict who is likely to respond.
Those are very precise targets. What if a clinic doesn't have the equipment for pressurized TCM? Is there another way to guide decisions for, say, diabetic foot ulcers?
Yes, they provided an alternative. They suggested type 2 level B, considering HBOT for diabetic foot ulcers that are pretty severe, classified as Wagner grade 3 or higher, or Texas stage B grade 3 or higher if they haven't improved after at least 4 weeks of good standard wound care.
And that standard care is crucial, right? HBOT isn't a magic bullet on its own.
Absolutely not. The panel was very clear on this. They strongly recommended, type 1 level B, that HBOT must always be part of a comprehensive multidisciplinary plan. That includes ongoing expert wound care.
You mentioned 4 weeks of standard care first. Was that a firm requirement?
Yes, type 1 level C recommendation for at least 4 weeks of appropriate standard care before starting HBOT. And critically, that standard care must include a proper vascular assessment.
To check the blood flow.
Exactly, type 1 level C. To see if the patient needs procedures like angioplasty or bypass surgery to improve circulation first. Poor blood flow is often the underlying problem, and they reiterated that TCGOM is really the best tool we have for selecting patients and monitoring progress for wound healing.
Okay. What about skin grafts or surgical flaps that aren't doing well? It seems like oxygen would be critical there.
It often is. The panel suggested HBOT, type 2 level C, for compromised grafts and flaps. But importantly, they gave a strong recommendation, type 1 level B, to start HBOT as soon as possible once a problem is identified. Don't wait.
And how do you know if there's a problem?
They recommended using clinical judgment combined with objective measures like TSOM again, or perhaps laser Doppler, to assess tissue viability, type 1 level B. They even suggested a typical HBOT treatment schedule.
Any situations where it's recommended even before a potential problem arises?
Yes, a strong recommendation, type 1 level C, to use HBOT both before and after surgery in high-risk situations. For example, if the surgery involves an area that was previously irradiated, or if it's infected, or if the patient is immunocompromised, it can help prepare the tissue and improve outcomes.
The conference report also touched on a few other conditions where HBOT might be accepted, right? Just quickly.
Yes, briefly. Things like a vascular necrosis of the femoral head, a hip problem, also severe burns, over 20% body surface area, but specifically in specialized burn units. Central retinal artery occlusion, a sudden eye issue, a rare bowel condition called pneumatosis cystoides intestinalis, and chronic bone infections, osteomyelitis, that haven't responded to anything else.
And the recommendations for those were mostly type 2 or 3?
Generally, yes. Suggested or optional, based on the available evidence for those specific conditions.
Okay, now for the flip side, what about conditions where the evidence just wasn't there, the non-accepted indications?
Right. They categorized some conditions as having level D evidence, meaning very limited or poor quality data. For these, they didn't make specific recommendations for HBOT.
Which conditions fell into that category?
Things like infection after open heart surgery, post-stenotomy mediastinitis, a severe ear infection called malignant otitis externa, acute heart attack, the eye disease retinitis pigmentosa, and Bell's palsy, the facial nerve paralysis. Basically, not enough evidence to say yes.
And then crucially, the conditions where they actively recommended against using HBOT.
Yes, these are the type 1 negative recommendations based on evidence showing a lack of benefit. It's really important listeners hear this.
What conditions are on that list?
Autism spectrum disorders, that was level B evidence against it. Placental insufficiency during pregnancy, level C against. Multiple sclerosis, level B against. Cerebral palsy, level B against. Tinnitus, or ringing in the ears, level B against. And importantly, the acute phase of a stroke, level C against.
So for those conditions, the expert consensus, based on the evidence available in 24/6/2017, was clear. HBOT is not indicated.
Exactly. The evidence just doesn't support its use for those specific problems.
Finally, did the conference offer any general advice on the practice of hyperbaric medicine itself? How centers should operate?
They did include some broader recommendations. They stressed that hyperbaric facilities, certainly within Europe, should really stick to the established European Code of Good Practice and the list of indications from this consensus document.
What about using HBOT off-label for conditions not on the accepted list?
They said if you're going to consider that, it requires a very thorough discussion with the patient about the potential benefits versus the risks, and importantly, the lack of strong supporting evidence. Informed consent is key.
And staffing. Training.
Huge emphasis on that. They called for standardized, comprehensive training for everyone working in hyperbaric medicine, doctors, nurses, technicians. Safety and competence are paramount.
That research?
Yes, a strong push for more research. They encourage physicians involved in HBOT to actively participate in both clinical trials and basic science research to keep building that evidence base, improve understanding, and potentially identify new valid uses or refine existing ones.
Well, this has been an incredibly detailed look at that 10th European Consensus Conference.
Thank you.
It seems the big takeaway is that this provides a really solid, evidence-based roadmap for using HBOT.
It really does. It shows where HBOT has proven value. Think CO poisoning, certain severe infections, specific wound issues, radiation complications. But it also clearly maps out where it's not supported by evidence, like for autism or MS. It's not a cure-all.
And these guidelines are just so vital, aren't they? For doctors making treatment decisions, for hospitals allocating resources, and ultimately for patients receiving appropriate care.
Absolutely. And for you listening, it hopefully highlights the rigorous process that goes into creating reliable medical guidance. It's not just guesswork. It involves careful evidence review and expert agreement.
It definitely does. It leaves me thinking, though, given that some uses were suggested or optional, maybe based on level B or C evidence, what happens next?
That's the key question, isn't it? What kind of future research, maybe new trial designs or technologies, might shift those recommendations? Could some type 3 uses become type 1 with better evidence? Or might some current uses be questioned further?
Exactly. It really makes you consider the dynamic nature of medical knowledge. What questions does this deep dive raise for you about how we evaluate treatments and where hyperbaric medicine might go in the future? Something to think about.